Most of us are here because we do hip replacements because they're so successful. But sometimes they don't work and patients are not happy and we feel bad about it. And we are obliged to make them better. So there are many tips and tricks of doing hip replacements. I'd like to share some of the ones that I've learned over the years, mostly from making mistakes myself. Some that I've learned from my revision practice and some that I learned from seeing residents struggle. What I won't be talking about are the pros and cons of any particular approach or implants, and not much about the new hip and spine relationship philosophies. So what are we trying to prevent? We're trying to prevent loosening, dislocations, periprosthetic fractures, leg length discrepancies, and things like that. And what I'd like to talk about are certain aspects of the whole spectrum of how to do a hip replacement. It's not something that I can cover today, but we'll hit the main points. This is what I tend to teach my residents about pre-op checks. I call it the 5 C's. I make sure that I check the indication because sometimes the pain has changed, sometimes a different joint has become involved now. Or the implant might need to be changed. I check clearances. I need to make sure what the cardiologist has said about the anticoagulation, for example. I check the skin to make sure that there are no rashes and no open wounds. And I check circulation and sensation and have to document it. Anyone with a spine issue, for example, who may have a residual foot drop, it is important to document that preoperatively so that you're not surprised postoperatively. And of course, you then can send the patient appropriately. One of the things I always tell the patient about, which we never taught, is to tell them that it is very likely that their operated leg might be longer or feel longer for a while after the surgery. You don't want the physical therapist telling them that, or they will get sensitized to it. Templating is very near and dear to my heart. I template every patient because it focuses my mind. It brings to mind the kind of bone that you might be seeing. It brings to mind the size of the bones. This patient is a 17-year-old girl with TB of her hip. And until I templated the hip, I didn't realize that the cup size was only about 40 and the stem was extremely small. And we had to specially order the stem size. This patient looked pretty straightforward until he stood up and he had this giant wingspan. And when I templated him, his offset was nearly 70 millimeters, which far exceeds any of the implants that we have. And I had to then postpone his operation and order a custom implant. Other deformities that I like to pay attention to are varus necks, because these can be difficult to balance, and protrusia. You do not want to end up with this kind of a patient who everything looks good, but because of the reduced offset, he is miserable. There are 3 main steps, I think, to templating, but I've broken them down further into 10 steps. The 3 main steps are you address the cup, the leg length discrepancy, and then the stem. So let's go to the 10 steps here. The first thing to do is to get a radio-opaque marker. The x-rays have to have a radio-opaque marker to calibrate them, whether you are doing it digitally or with acetate templates. It is important that the radio-opaque marker is in the same coronal plane as the hips, and you should get a low AP pelvis with no rotation. I typically tend to use either a metal ball, which I bought from Amazon, which is 1 inch in diameter, or you can just use a quarter that you stick to the medial side of the thigh, dropping it into a glove. It's important to get a good view of the hip joints as well as the proximal femurs. I want to be able to see the calcar cortex and the lesser trochanter hiding behind it. I want to be able to see a good view of the pelvis, and an X-ray like this is not really adequate because you cannot see the proximal femurs. An X-ray like this is not really appropriate for templating, but has to be accepted because the patient may not be able to internally rotate their limbs because of the stiffness in the hip. But you have to be aware of this. If you see the lesser trochanter more easily, it's likely that the leg is externally rotated and the neck may appear shorter than it is, and it may appear more valgus than it is. The next step is to calibrate the image. Most digital softwares will do that automatically, but you should be aware of how most PAC software will allow you to calibrate a radio-opaque marker as well. The next step is to size the head. I like to use the cup template to size the head because I'll use this intraoperatively to validate the templating. And once I measure the head size, this is a surrogate of the AP diameter of the acetabulum, and therefore helps me not overream the acetabulum and blow the anterior and posterior walls off. So once I measure the head size, I add 4 and 6 millimeters to it, and I get 2 numbers. And these are the most likely cup sizes that I will find intraoperatively, provided the calibration is close. The next step is to establish the hip center. So I then move the cup, the templated cup, medially up to the ilioscale line and inferiorly up to the just past the teardrop. Once I do that, I confirm the inclination, and now I have bought the hip center and the position of the cup. And this is what I try to execute intraoperatively. The next step is to measure the leg length discrepancy. And this is to give you a target leg length after the surgery. And there are different methods of measuring leg length, but you have to find an appropriate landmark on either side of the pelvis and an appropriate landmark on either femur, on both femurs, that you can see clearly. And you can use different lines. You can use a line at the bottom of the ischial tuberosities, a line at the bottom of the foramen, or through the teardrops. You can use the corner of the lesser trochanter, the apex of the lesser trochanter, or the tip of the GT. Once you know the leg length discrepancy, we go to the sizing of the stem. And I use the Goldilocks test. I try a small stem. I go, this is too small. And I go up a few sizes, and I go up to an extra large stem, and I go, this is too big. And then I find the sweet spot where I see just a little bit of sunlight between the implant template and the cortex. And I know that this stem is appropriately sized for this calibrated image. And I want to be able to see that the calcar of the implant matches the calcar of the femur. The next 2 steps establish the offset of the patient. And that is to do with the neck angle and the neck length. So determine the neck angle. Most implants will have a standard stem and a coxavera stem. And and I think you have to try both to see which one will allow you to choose the best offset and leg length for the patient. The next step would be to determine the neck length. And the neck length is inversely proportionate to the depth of the bore of the head. So the deeper the bore, the shorter the neck length. And again, we do a Goldilocks test to see which is the best neck length to allow you to restore the offset. And finally, I measure two distances, what I was taught to call the LT-HC distance and the NC-HC distance. The LT-HC distance is the distance from the lesser trochanter to the hip center. And the NC-HC distance is the neck cut to the hip center distance. These are the numbers that will hang in my OR on the screen. And these are something that I will try and reproduce intraoperatively. And I can do this both by posterior approach as well as with an anterior approach, because these would be a surrogate of the leg length and offset. So in summary, the templating gives you your cup size, your stem size, and you need to restore your leg length and offset. Okay, moving on. Some of the tricks with the posterior approach, I like to make sure that my operative hip can flex at least to 90 degrees, if not more, and that the pelvic positioner is not impeding the flexion of the hip. I also like to make sure that the space in front of the down leg is empty, because this is really important during the flexion, adduction, and internal rotation maneuver while addressing the femur, because you want a clear shot down the femur. And if this hip, the down hip is flexed too much, and the knee, the contralateral knee impedes this flexion and adduction, you are really struggling and fighting the soft tissues to address the femur. This is just another couple of views of the same thing. A couple of points about retractors that I teach the residents. When putting the anterior retractor over the anterior wall, try and avoid the 3 o'clock position, and it should really go somewhere between the 2 o'clock and the 12 o'clock position. With retractors that go deep to the TAL, I would teach my residents not to go anteriorly, but to go more posteriorly, because there's the acetabular branch of the obturator artery and nerve, and the obturator nerve and artery itself are actually very close by. Some of the tricks with the anterior approach, I like to keep my my hip slightly flexed, both because of the fixed flexion deformity that inadvertently happens, but also because it detensions the psoas, and I find that retracting it out of the way is easier with the hips flexed. I also use a shower curtain for my drapes with a blue towel over the perineal post. The reason for the shower curtain is that I can see the limb quite clearly, and I can also see the limb to make sure that it's not coming off the boot when dropping the spar. I also like to be able to look at the toes so they're not turning purple, things like that. Here's a trick that I learned from ViewMedi. Unfortunately, that video was taken down for some reason, but I found that it was really quite useful. This is during the anterior approach. Before I make my capsulotomy, I create this potential space, and I create a space that is actually a potential space between the gluteus medius tendon and the greater trochanter. I put a Homan in there and release the soft tissues, which are nothing really, but this allows the superior capsule to be identified. And then when I finally do my capsulotomy, I'm making my release right about here, which actually helps later on while addressing the femur. I also teach my residents to make what is called a metal hammock. This protects the posterior structures when using the saw. I also teach my residents to do just an anterior cut in the cortex of the neck first, then proceed distally, complete the distal calcar cut, and then come back proximally and bounce the saw blade very, very carefully and slowly, because if you plunge, you may damage the posterior greater trochanter, but also you may damage the ascending branch of the medial circumflex, which can bleed a lot. Another trick that I had to teach myself was I used to put the anterior retractor underneath the psoas tendon, but after I had a few patients that had psoas tendonitis, I started putting the retractor between the capsule and the labrum, and it actually gives a pretty good view of the labrum to excise it, and also be able to see the anterior rim when I'm putting my cup in. I also found that releasing the capsule on the medial side all the way down to be able to feel or see the lesser trochanter right at the beginning helps move the femur away from the acetabulum and gives a better view of the acetabulum. When addressing the femur, I teach my residents to put the retractor more posteriorly and not anteriorly to support the bulk of the trochanter to prevent fractures. A couple of words about acetabular sizing. As I mentioned before, as I excise the femoral head, the first thing I do is I measure the diameter of the femoral head. This does a couple of things. One is that it validates my templating. And if I find that I've undersized or oversized my templating, then I know that my implants may actually be slightly off. But I add 4 millimeters and 6 millimeters to the size of the femoral head that I measured. And this gives me an estimate of what the final reamer and possibly the cup's going to be. And this is very important because if as I approach that number, that size of the acetabular reamer, I want to make sure that I'm getting my chatter and my kickback that I feel. And if it isn't, then that means that something is wrong. In terms of positioning the acetabular cup, this can be done either with a posterior approach or an anterior approach or any other approach. I tend to use the TAL as part of my checks. The inferior rim of the acetabular cup or reamer should be slightly anteverted to the TAL, and I like to see a slight V sign right here. This would indicate that this cup is neutral, and this would indicate that the cup is retroverted. But I also like to make sure that the anterior rim of the cup is just deep to the anterior wall of the acetabulum. Some of the tricks on the femoral side, this is something that I was taught in fellowship. When doing the posterior approach, before I excise the head, I would drill a hole or make a bovie mark right here at the neck, lesser trochanter corner, and measure this distance from the lesser trochanter to the hip center. Imagine an equator around the head here and the center of that equator. And I use a paper ruler that comes with a skin marker to measure this distance. This distance should be very similar to the templated LT-HC distance. And this is, again, another validation step for my templating. Irrespective, I like to use this to reconstruct my leg length and offset. And this picture just shows what that actually means. Some of the tips for avoiding varus, as you know, using uncemented stems, varus positioning is not that critical, but what I really want to talk about is that if the stem is in too much of varus, it can be undersized and then later subside, or it can end up causing a fracture intraoperatively. And I want to bring your attention to this particular area of the bone, which I call the NGT junction, which is the neck greater trochanter junction. There's a sclerotic bar of bone right here that can prevent the stem from entering into the femoral canal. This is another picture showing exactly what this means. And so it is important to excise this bar of bone to allow better seating of the implant. Talking of calcofractures, if this does happen, the established wisdom is that you remove the implant, apply a cable around the proximal femur, avoiding catching the psoas tendon, and then reinsert the same implant. Quick reminder about cementing. I cement implants when the patient is osteoporotic. If they have radiated bone, or if I find that after I've tried my trial implant and I'm not getting the right stability, I might decide to cement. And of course, if you're doing somebody such as a multiple myeloma patient, you might want to cement as well. I won't go into details here, but one of my residents, Dr. Pedada, came up with this matrix after I did a lecture on templating. And this is something that I'd like you to either take a screenshot or take a photograph of, but I won't go into details. This is very similar to the sagittal balancing of the knee, and we're in the process of trying to write a paper about it. And this is the same thing for cemented hips as well. In terms of new technologies that are present and in the future, we mentioned robotics with knees. Robotics are here for hips as well, patient-specific jigs, and I'll tie in hip and knee, hip and spine relationship as well. To me, the robotics, the promise of robotics is this process wherein you can do a preoperative plan before you work on the patient. You then validate and check the integrity of your plan during surgery, and then you execute that plan, which the robot is meant to do very precisely. That's the whole philosophy of why robots may be the established technique in the future. You can choose the position of the implant preoperatively, either on a CT scan or plain images. You can even position the femoral stem at where you want it to be and check for leg length and offset, etc. And some systems even allow you to see what the post-op X-ray may look like after the surgery. They are bulky, they're getting smaller, they are expensive, and I think they are probably here to stay. In terms of other technologies, there are available technologies that will allow you to choose the position of the cup that is specific to the patient, taking into consideration the position of the pelvis with the patient sitting and standing and stair climbing. And the company can make patient-specific jigs to allow you to choose the correct position